Okay, now let's end our discussion of the cardiovascular system with vessels and circulation. So in this lecture, we'll talk a little bit about the anatomy of the different vessels in the body, and then we'll go into the physiology of blood flow, blood pressure, and perfusion, and we'll talk a little bit about regulation of blood pressure. So we've already mentioned there's three general types of blood vessels. There's arteries that are going to carry blood away from the heart. There's capillaries. These are tiny, tiny blood vessels that exchange substances between the blood and the tissues. And then there are veins, and these guys transport blood from those capillaries back to the heart. Now, the walls of vessels are going to be composed of three layers, and these layers are called tunics. There's the tunica intima, the tunica media, and the tunica externa. The space inside of the vessel where the blood actually flows through is called its lumen. The tunica intima, this is the innermost layer of the vessel wall. It's composed of the endothelium. This is a simple squamous epithelium, as well as a subendothelial layer of areolar connective tissue. Then you have the tunica media. This is the middle layer of the vessel. It has circularly arranged layers of smooth muscle cells with elastic fibers. And when these guys contract, it causes vasoconstriction, that is, the lumen narrows. And when they relax, it causes vasodilation, that is, the lumen widens. Finally, you have the tunica externa. This is the outermost layer of the vessel. It's going to be composed of areolar connective tissue with elastic and collagen fibers. And it's going to help anchor the vessel to other structures. Now, in some vessels, it may contain the vasa vasorum. These are small arteries that are required to supply the walls of very large vessels, such as the aorta. Okay, so here we have a few different vessels laid out, and you can see the different tunics of them. So on the left is an artery, and you can see right here is the tunica intima. And then going further outwards, you have the tunica media. Remember, this is going to be composed of primarily smooth muscle. Then going even further outwards, you have the tunica externa. And you can see the small vasa vasorum throughout that externa. You can see the same thing laid out over here in the vein. Here's the tunica intima. The tunica media we'll talk about is much smaller or much thinner in veins. And then here's that tunica externa again with vasa vasorum throughout it. And then here are the capillaries. And if we were to zoom in and look at what composed a capillary, we would see that it's primarily just an endothelial layer with a basement membrane. All right, so we're going to compare the different vessel types. Before that, let's define companion vessels. These are going to be arteries and veins that lie next to each other and serve the same body region. And this, you'll find, is a good number of the arteries and veins throughout the body. Arteries are going to have a thicker tunica media and a narrower lumen compared to veins. They also have more elastic and collagen fibers. This allows the artery to spring back to shape after blood has gone through it. These arteries are going to be more resilient and resistant to changes in blood pressure because of that. Veins, on the other hand, have a thicker tunica externa and a larger lumen than arteries do, and they have less elastic and collagen fibers. And so you'll see that the wall of a vein can collapse if there's no blood inside of that vessel. All right, here's a microscopic comparison of an artery and a vein. So down here we have the artery. You can see this really thick tunica media here. And you can see a narrower lumen than over here with the vein, which has a much larger lumen and a much thinner tunica media. Capillaries. Capillaries, we said, contain only the tunica intima. So they're going to be composed of an endothelium and a basement membrane. They have no subendothelial layer. This thin wall allows for rapid gas exchange and nutrient exchange at the tissue level. Okay, this is what a capillary looks like under electron microscope. Okay, so these guys are so small, they're really hard to distinguish under just a plain light microscope. So here we've got a really magnified image of a capillary. So this is the capillary wall, and it's composed of a single endothelial cell. Here you can see it kind of folds back onto itself. You can see the organelles scattered throughout that endothelial cell. You can see the nucleus. Here, this big black area of the endothelial cell. This is the actual lumen of the capillary, and you can see inside of it this red blood cell. So capillaries are tiny. They're just big enough to fit red blood cells through. Okay, and then just outside of that endothelial cell, you can see the basement membrane. Okay, as arteries travel outward from the heart, they're going to branch into smaller and smaller vessels. So as they branch, they're going to decrease in their lumen diameter, so their lumens get smaller. They're going to decrease in how many elastic fibers they have, so they're less able to stretch and recoil. And they're going to increase in the relative amount of smooth muscle that's present. There's three basic types of arteries. There are elastic arteries, muscular arteries, and there are arterioles. Elastic arteries, also called conducting arteries. These are the largest arteries in your body. They're going to be conductors of blood from the heart to the muscular arteries. They have a large proportion of elastic fibers in their wall that allows them to stretch and recoil. And so they stretch when blood is pumped through. And then that recoil helps propel blood through the arteries while the heart rests during diastole. Examples here would be the aorta, the pulmonary trunk, the common carotid, and the common iliac arteries. Next, you have the muscular or distributing arteries. These are medium arteries, and they're going to distribute blood to specific body regions. Smooth muscle is going to allow for vasoconstriction and vasodilation. They have elastic tissue. They have an internal elastic lamina between the tunica intima and the tunica media, and an external elastic lamina between the tunica media and the tunica externa. Most arteries, most named arteries, are going to be muscular arteries. Next, you have arterioles. These are the smallest arteries. Larger arterioles have three tunics. The smaller arterioles have only a thin endothelium and a single layer of smooth muscle. The smooth muscle is usually a little bit constricted. This we call vasomotor tone, and it's going to be due to sympathetic tone. Remember, that's when the sympathetic nervous system is kind of always on, always sending a little bit of a signal to its effectors. These guys regulate systemic blood pressure and blood flow. They're incredibly important in this regard. All right, here's what an elastic artery looks like under the microscope. So going from outside to inside, we have the tunica externa out here. Next, we have the tunica media, our middle layer. It's going to be composed of smooth muscle and elastic fibers, and you can see these elastic fibers are kind of these pink squiggly lines running throughout, so lots and lots of elastic fibers that allow for stretch and recoil. And then here, this single layer here that you see is the tunica intima, and then here's the lumen. Here's a muscular artery. You can see the tunica externa, the tunica media, thinner in the muscular artery than it was in the elastic artery, and also fewer elastic fibers. And then you can see the tunica intima. Also note the internal elastic lamina here and the external elastic lamina here. And then down here we have an arteriole, and here you can see the tunica media, and then the tunica intima, and then the lumen here. All right, let's talk a minute about atherosclerosis. This is a progressive disease of the elastic and muscular arteries, and it causes the presence of these things called atheromas, or plaques. And what a plaque is composed of is primarily lipids, cholesterol, calcium, and then inflammatory cells like macrophages. And what happens is all of these things thicken the tunica intima, and that causes a narrowing of the arterial lumen. Now, we think atheromas might be formed in response to injury to the endothelium. This injury can come through a variety of ways: by infection, by trauma, high blood pressure, even toxins such as cigarette smoke. Okay, so this is known as the response to injury hypothesis. And what happens is injury results in a cascade of events, including inflammation and lipid deposition, and ultimately an atheroma is formed. Now, the atheroma doesn't just stay there. It enlarges over time. More stuff gets added to it. And as that atheroma enlarges, the lumen of the artery becomes narrower, and this restricts blood flow to the region that artery supplies. Plaques can also break off and travel further downstream to narrower arteries and arterioles where they can obstruct blood flow completely. Risk factors for atherosclerosis. There are a lot of risk factors, but one of the biggest ones is going to be hypercholesterolemia, or increased blood cholesterol. Smoking cigarettes and uncontrolled chronic high blood pressure also increases risk of vascular injury and therefore overall risk of atherosclerosis. Treatments. So, if there is a plaque that has grown to the point that it's obstructing a vessel, such as a coronary artery, what they will do is they can do angioplasty. This is a procedure where they thread a small balloon up through your arteries to the artery in question, for example, a coronary artery, and they expand that balloon. They blow it up inside of the artery, and that kind of packs the plaque down against the artery wall and opens the artery up again. Now, if the obstruction's bad enough, they might need to do a bypass surgery. For example, coronary bypass surgery. This is where they take a vessel, usually a vein from the leg, and then they graft it from the aorta to the heart or to the coronary artery, bypassing the blockage. Okay, aneurysm. This happens when a part of the arterial wall thins and then it balloons out, and this makes the wall more prone to rupturing. When it ruptures, it can cause massive bleeding and death. The elastic and muscular arteries, as you age, are going to be less able to withstand forces from pulsating blood. So, risk of aneurysm is going to increase as the age increases. You're going to see aneurysm is most common in the aorta or the arteries at the base of the brain. This is an example of an aortic aneurysm, specifically an abdominal aortic aneurysm. So you can see this is superior, this is inferior, here are the kidneys. So this is on the abdominal aorta, just inferior to the kidneys. And this is not an uncommon place for an abdominal aneurysm to form because this portion of the aorta is structurally weaker. The infrarenal aorta has less elastic in its tunica media. It's also thought to have a less robust vasa vasorum. So the vasa vasorum are thought, at least, to not supply the tunica media as well as the vasa vasorum in the thoracic aorta do. So the wall is relatively deprived of oxygen and nutrients, and over time this can lead to loss of structural integrity. Okay, capillaries. These are the very, very small vessels that connect arterioles to venules. Their average length is about 1 millimeter. Diameter is very small, 8 to 10 micrometers. The wall of a capillary consists of an endothelial layer on a basement membrane, and that's all. This thin wall and the small diameter of the capillary are optimal for exchange between the blood and the fluid in the tissues. There are 3 types of capillaries we're going to talk about: continuous, fenestrated, and sinusoid. All right, first are continuous capillaries. Here you can see the endothelial cells form a continuous lining. So there's really no holes or big gaps in this capillary. Now, the tight junctions do connect the cells here, but they don't form a complete seal, so some stuff can get through. The intercellular clefts are those gaps between the endothelial cells, and while large particles cannot pass, smaller particles such as glucose can make it in between those endothelial cells. These kind of capillaries are very common. They're found in muscle, skin, the lungs, and the CNS. Okay, next are fenestrated capillaries. So here, again, the endothelial cells form a continuous lining, but the cells themselves have fenestrations, or pores. These pores allow movement of smaller plasma proteins. And you're going to find these capillaries in areas where a lot of fluid transport is happening. So, for example, intestinal capillaries absorbing nutrients, or capillaries in the kidney filtering blood to form urine. Finally, you have sinusoids. Here, the endothelial cells form an incomplete lining, and you can see they have these large gaps here. The basement membrane is also incomplete or completely absent. So these large openings allow for transport of bigger substances. So things like the formed elements in blood, large proteins. You're going to find these capillaries in the bone marrow, in the spleen, and in some endocrine glands. All right, capillary beds. What is a capillary bed? Well, it's just going to be a group of capillaries functioning together. A capillary bed is going to be fed by a metarteriole. This is a branch off of an arteriole. The proximal part of the metarteriole is going to be encircled by smooth muscle cells. The distal part, called the thoroughfare channel, has no smooth muscle cells. And the metarteriole is going to connect to a postcapillary venule, draining the bed. True capillaries are going to branch off of that metarteriole and make up the bulk of the capillary bed. So let me show you what that looks like. Here's your arteriole, and then you can see the metarteriole coming off of it. Here at the proximal end, you have it encircled by scattered smooth muscle cells. Here at the distal end, there's no smooth muscle cells. And then you can see this straight portion, the thoroughfare channel, and then it connects directly to the post-capillary venule. You can see true capillaries arising from the metarteriole here in the middle. Okay, the precapillary sphincter. This is a smooth muscle ring at the origin of a true capillary. And sphincter relaxation is going to allow blood to flow into that true capillary, while contraction of the sphincter is going to cause blood to bypass the capillary bed. Perfusion. This is the amount of blood entering the capillaries per unit time per gram of tissue, so milliliters per minute per gram. And remember, the goal is to have adequate perfusion. And adequate perfusion is when oxygen supply meets oxygen demand. All right, back to this image. You can see the precapillary sphincters here at the origin of the true capillaries. And this image is showing them relaxed. so the capillary bed is well perfused. Compare that to this image where those precapillary sphincters have contracted, and so blood is being shunted or bypassed to the thoroughfare channel and then back to the venule. Okay, speaking of venules, what is a venule? Well, a venule is going to be the smallest kind of vein there is. Diameters here of 8 to 100 micrometers. These guys are companion vessels to arterioles. The smallest venules are post-capillary venules, while larger venules can have all three tunics. Ultimately, venules are going to merge in order to form veins. All right, small and medium-sized veins, these guys are going to be your companion vessels to the muscular arteries. And then your largest veins are going to travel with the elastic arteries. Now, most veins of these sizes are going to have numerous valves. And what valves do is they prevent blood from pooling in the limbs and ensure flow towards the heart. Valves are going to be made of the tunica intima as well as elastic and collagen fibers. So they have a very similar structure to the heart's semilunar valves. And you can see a valve here. And so this would be inferior towards the feet. This would be superior towards the heart. So blood flows up towards the heart, and then gravity wants to pull it back down. But these valves snap shut and prevent that blood from dropping all the way back down. Veins are really important blood reservoirs. That is, there's some place in our body that we can stash and store blood for later. At rest, about 70% of your blood is in the systemic circulation. So that's going to be your systemic veins, your systemic arteries, and your systemic capillaries. 18% of blood is going to be in the pulmonary circulation, while the heart holds about 12% of the blood. Now, in the systemic circulation, you'll notice that the systemic capillaries only have about 5% of the blood volume. The systemic arteries have about 10% of the blood volume. That means the vast majority of the volume of blood in your body is hanging out in your systemic veins. Why is this significant? Well, if something were to happen and you needed higher blood flow, for example, you start exercising and so you need to get more blood out to your muscles, the systemic veins can constrict and your muscles can pump the blood from the veins up to your heart. We'll talk about that in a little bit. And you basically move that blood out of storage into your systemic arteries and capillaries. Okay, so you shift the blood away from the veins into the other vessels of the body. All right, so we said blood can be moved from the veins into the circulation through vasoconstriction of veins. So we do this when we need more blood during, for example, exertion. Blood can then be shifted back into the venous reservoir via vasodilation. So you just dilate your veins and you can store blood in your veins, for example, during rest. Okay, let's talk about blood vessel pathways. So there's the simple pathway, and then there's a bunch of different alternative pathways. So the simple pathway is going to involve one major artery that delivers blood to an organ or to a body region. An end artery is going to be the artery in this case, and what an end artery is one that provides only one path for blood to reach an organ. So it only has one path from A to B. It's going to branch into smaller arteries at its end that then become arterioles. Those arterioles feed into capillary beds. Those capillary beds are going to be drained by venules, and all those venules are going to merge to form one major vein. An example of a simple pathway would be in the spleen. So you have the splenic artery that delivers blood to the spleen. So the splenic artery comes in and it branches into smaller arteries that then become arterioles that then branch into capillary beds, feed capillary beds, and then the capillary beds are going to drain into venules. Those venules are going to merge into the splenic vein, and that splenic vein is going to drain the entire organ. That's a simple pathway. You can have alternative pathways. You can have an arterial anastomosis, and what an anastomosis is just basically a connection of one vessel to another vessel. So an arterial anastomosis is where two or more arteries converge to supply the same region. Venous anastomoses are going to be more common than arterial anastomoses. So a venous anastomosis is where two or more veins drain the same organ or body region. Example here, basilic, brachial, and cephalic veins that drain the upper limb. And then there's the arteriovenous anastomosis, or AV anastomosis. This is also called a shunt. What happens here is it's going to transport blood from an artery directly to a vein, completely bypassing capillary beds. You have AV anastomoses in your fingers, and your toes, and your palms, and your ears. So this allows those areas to be bypassed if the body becomes hypothermic, okay? And that keeps the blood away from the body surface so it doesn't cool down more. Okay, and then you can have what's called a portal system, and you've already seen one of these in the endocrine chapter. A portal system is where two capillary beds are connected to each other. So the path here is going to be an artery to a capillary bed, to a vein, to another capillary bed, to a vein, okay? And the vein that is connecting the capillary beds is specifically called the portal vein. Examples here are in that hypothalamus, okay, where the hypothalamus communicates with the anterior pituitary, and also in the hepatic portal system, okay? There's a big portal system in your liver that we'll talk about when we get to the digestive chapter. Okay, so let's take a look at the different pathways. Up top we have the simple pathway. So you're going to have a single artery that comes into a body region or an organ, and it's going to branch into a bunch of different arterioles, and those arterioles are going to feed capillary beds, and then those capillary beds are going to join venules, and those venules are going to join together to form a vein, and the vein drains that organ or body region. Now, what happens if you get a blockage right here in the artery? Well, all blood flow distal to that blockage is going to cease. Okay, so you're going to completely block blood from supplying that organ or body region. That is a problem with the simple pathway. Let's look at an example of arterial anastomoses. Here you see several arterial anastomoses. The singular of anastomoses is anastomosis. So here we have several, so it's going to be anastomoses, and these guys all converge to feed the same capillary beds, the same region, the same organ. Okay, and the significance here is, let's say you get a blockage right here at this artery. Well, you're going to lose blood flow all downstream of that. However, blood can come in this way and feed through these anastomoses and feed this region. Okay, so you can get blood flow through those anastomoses that feed the region that's being blocked, that's being cut off by the blockage. So that's what makes arterial anastomoses so significant. Venous anastomoses, these are common throughout the body. This is where several veins anastomose come together to drain the same region or organ. Here's an example of an AV shunt. So here we have an artery that directly connects to a vein. And so blood can be shunted this way and completely bypass this organ or body region. And then finally you have a portal system. So here we have the artery, feeds a capillary bed, then that capillary bed, it gets drained by a vein, but that vein, instead of going to the heart, is going to go to another capillary bed. And then that capillary bed is going to be drained by a vein that ultimately goes back to the heart. Okay, now let's talk a little bit about blood flow and blood flow velocity. So the cross-sectional area of a single vessel is the diameter of its lumen. Total cross-sectional area is going to be the sum of all diameters of all vessels of a certain type. So, for example, all arteries, all capillaries, all veins. Collectively, the total cross-sectional areas of capillaries is going to be the largest of all of those. And that's just because there are so many capillaries throughout the body. Blood flow velocity is going to be inversely related to that total cross-sectional area. That is, the higher the total cross-sectional area, the slower the flow. This means that the blood flow is really slow in capillaries, and this is good because this allows for exchange of those nutrients and those gases between blood and the tissue fluid. All right, this is showing total cross-sectional area here in blue. This is showing blood flow velocity in red. The numbers for total cross-sectional area are over here on the left. The numbers for velocity of blood flow are over here on the right. So you can see blood flow velocity is really high in the elastic arteries, but it's going to drop as it goes throughout the distributing arteries into the arterioles and into the capillaries, venules, and veins. The cross-sectional area is really low in the elastic arteries. It gets a little bit higher in the muscular arteries. There's more arterioles, so it gets higher still. And then total cross-sectional area is going to be highest in the capillaries. And remember, this is just because there are so many capillaries in the body. And really all this chart is trying to show you is that when total cross-sectional area is at its highest, at its peak, blood flow velocity is at its lowest. Okay, let's talk a little bit about capillary exchange. So what goes on at the capillary level? How are we exchanging substances, gases, nutrients, wastes, hormones? Well, there's several processes involved. So these processes include diffusion, vesicular transport, and bulk flow. Okay, first there's diffusion. This is where substances leave or enter the blood according to their concentration gradient. And remember, substances are going to flow from areas of high concentration to areas of low concentration. Oxygen, hormones, and nutrients are going to move from the blood to the interstitial fluid, while carbon dioxide and wastes are going to diffuse from that tissue into the blood. The route that diffusion takes is going to depend on the size of the particle. Small solutes like oxygen can diffuse straight through endothelial cells or through their intercellular clefts. Larger solutes, for example some proteins, are going to pass through fenestrations or gaps in sinusoids. Endothelial cells can also use vesicular transport. And what this is pinocytosis and exocytosis. So what these endothelial cells can do is they can take substances into themselves by pinocytosis. So remember, they form those fluid-filled vesicles at the plasma membrane and kind of engulf that vesicle. The vesicle is then transported across the cell from one side to the other, and it's going to be secreted from that other side by exocytosis. This process can be used in both directions, so it can be coming from the blood and going to the blood. Certain hormones and fatty acids are going to be transported this way. Okay, and then there's bulk flow. And bulk flow is when fluids flow down their pressure gradient. Okay, so going back, diffusion, remember, is going to be substances going from their concentration gradient from high to low. Bulk flow is going to be fluids flowing from high pressure to low pressure. What you see is large amounts of fluids and dissolved substances moving, and movement direction is going to depend on the net pressure of opposing forces. That is, it's going to depend on the hydrostatic pressure, that is the pressure of blood to leave the vessels, versus the colloid pressure. Remember, the colloid pressure is those plasma proteins in the blood that draw water into the bloodstream through osmosis. So essentially it's hydrostatic pressure versus osmosis. You have two processes here. You have filtration and reabsorption. In filtration, fluid is going to move out of the blood. So fluid and small solutes flow easily through a capillary's openings. Large solutes here are going to be blocked. And this occurs on the arterial end of a capillary. Reabsorption is going to be when fluid moves from that interstitial space back into the blood. And this is going to occur on the venous end. Hydrostatic pressure, this is the force exerted by a fluid. So there's blood hydrostatic pressure and interstitial fluid hydrostatic pressure. Blood hydrostatic pressure is the force exerted per unit area by blood on a vessel wall. That is, just the force that blood is exerting on a vessel wall. And what it does is it promotes filtration from the capillary. That is, that force of blood on the vessel wall pushes fluid out of the blood vessels. On the other hand, you have interstitial fluid hydrostatic pressure. So this is the force of that interstitial fluid, the force that it's exerting on the outside of the blood vessel. And in most tissues, it's negligible. It's close to zero. But what interstitial fluid hydrostatic pressure does is it opposes blood hydrostatic pressure. Okay, and then you have the colloid osmotic pressure. We've already talked about this a little bit. This is the pull on water due to the presence of proteins in the blood. Remember, this is due to osmosis. Water wants to move from those that interstitial fluid, which is low in solutes, into the bloodstream, which has a lot more solutes. So there's the blood colloid osmotic pressure. This draws fluid into the blood due to those proteins, such as albumin. It promotes reabsorption. That is, it opposes that hydrostatic pressure, that blood hydrostatic pressure. Clinically, we call this the oncotic pressure. Okay, so blood colloid osmotic pressure clinically is called oncotic pressure. Then you have the interstitial fluid colloid osmotic pressure. This is the pressure that draws fluid into the interstitial fluid. There are few proteins present in the interstitial fluid, so this pressure is relatively low, 0 to 5 millimeters of mercury. Putting it all together, you can find the net filtration pressure. So the net filtration pressure is the difference between the net hydrostatic pressure and the net colloid osmotic pressure. So what you do is you take the blood hydrostatic pressure and you subtract the interstitial fluid hydrostatic pressure from that. You take the blood colloid osmotic pressure and you subtract the interstitial fluid colloid osmotic pressure from that. So now you have your net hydrostatic pressure and your net colloid osmotic pressure. And you subtract the colloid osmotic pressure from the hydrostatic pressure, and you get net filtration pressure. Now this net filtration pressure is going to change along the length of a capillary. It's going to be higher at the arterial end and lower at the venous end. So at the arterial end, this is going to favor filtration, that is, moving fluid from the bloodstream into the tissues, while at the venous end, it's going to favor reabsorption, so moving blood fluid from those tissues back into the blood. Okay, here we have it all drawn out for us. So here is the beginning of our capillary, the arterial end. And you can see net hydrostatic pressure here, which is blood hydrostatic pressure, which is 35 millimeters of mercury, minus interstitial fluid hydrostatic pressure, which is normally about 0. So the net hydrostatic pressure at the arterial end is 35 millimeters of mercury. Subtract from that the net colloid osmotic pressure. Colloid osmotic pressure of blood is 26, of interstitial fluid is 5, so the net osmotic pressure is going to be 21 millimeters of mercury. So 35 minus 21 is going to equal 14 outwards. So the net filtration pressure here favors filtration. Okay, now let's look at the venous end of the capillary. So here again we're looking at hydrostatic pressure. We have a blood hydrostatic pressure of 16 millimeters of mercury minus the interstitial fluid hydrostatic pressure, remember normally is 0. So here the net filtration pressure, the net hydrostatic pressure is 16 millimeters of mercury out towards the interstitial fluid. Over here, we're looking at colloid osmotic pressure. The colloid osmotic pressure of blood is still 26, of the fluid, interstitial fluid is still 5. So our net colloid osmotic pressure is still 21 millimeters of mercury drawing fluid into the bloodstream. And here you'll notice that that is higher pressure than the net hydrostatic pressure. So here at the venous end of the capillary, colloid osmotic pressure wins, and so you get a net filtration pressure of 5 millimeters of mercury into the bloodstream. Now you may look at this and realize that you have 14 millimeters of mercury pushing fluid outwards into the interstitial space and only 5 millimeters of mercury pushing fluid back into the vessel. So that means you have a net loss of fluid into the interstitial space. How do we get that fluid back? Well, that's where the lymphatic system comes into play. So you have lymphatic capillaries in the tissues that are going to pick up excess fluid that's not being reabsorbed at the venous capillary end. The lymphatic system then filters that fluid and returns it to the venous circulation. Changes in capillary exchange or absorption by the lymphatic system can result in edema. And remember, this is excess fluid building up in the tissues. Okay, not all capillaries are going to be filled simultaneously. Really, only about a quarter of the body's capillaries are open at rest. And so local blood flow is going to vary. Now, flow is going to be measured in milliliters per minute, and remember, it needs to be high enough to maintain adequate perfusion. That is, in order to match oxygen supply to oxygen demand. Local blood flow is going to be dependent upon several factors that we'll talk about one by one here. Degree of tissue vascularity, the myogenic response, local regulatory factors that alter the blood flow, and total blood flow. Okay, the degree of vascularization. This is the extent of vessels in a given tissue. Metabolically active tissues are going to have higher vascularity, so things like the brain, skeletal muscle, the heart, and the liver. Other structures are going to have little vascularity or are entirely avascular. Tendons, ligaments, epithelia, cartilage, cornea, and the lens of the eye. Angiogenesis is the formation of new blood vessels. And this is going to occur over a time period of weeks to months to increase perfusion to a particular area. Examples here are in skeletal muscle, you see angiogenesis in response to aerobic training. In adipose tissue, you see angiogenesis with weight gain. And in coronary vessels, you can see a little bit of angiogenesis in response to gradual blockage. But remember, coronary vessels are functional end arteries. That is, a blockage in one of them is going to completely disrupt blood flow distally to that blockage. They don't have strong enough anastomoses to divert blood around the blockage. Regression, this is when you return to the previous state of blood vessels, for example, in skeletal muscle after you become sedentary, or in adipose tissue when weight is lost. We see angiogenesis in tumors. So cancer cells, they are rapidly growing and dividing, so they require a high amount of oxygen and nutrients. And this is going to trigger the growth of new vessels as the tumor grows. So cancer cells secrete molecules that cause the body to release angiogenic growth factors that trigger the blood vessels to proliferate. And this is one avenue that researchers are exploring as a way to stop the angiogenesis of these cancer cells and therefore starve the tumor. The next factor that helps determine local blood flow is the myogenic response. And this is where smooth muscle in a blood vessel wall helps to keep local flow relatively constant. So as systemic blood pressure rises and more blood enters an arteriole, it's going to stretch that arteriole. The smooth muscle of that arterial wall will respond by contracting automatically, and this contraction is going to return local flow back to its original level. If, on the other hand, systemic blood pressure decreases, the amount of blood entering an arteriole decreases, so there will be less stretch. In response to this decreased stretch, the smooth muscle of the vessel is going to relax, and that relaxation is going to open up and allow local blood flow to come through to original levels. Now, blood flow is locally regulated, and remember, it's going to be based on need. So when oxygen demand increases, local blood flow is going to increase. And you'll see blood flow changes when metabolic activity changes or when the tissue is damaged. Now, there are some other things that can alter blood flow. Vasoactive chemicals. You have vasodilators and vasoconstrictors. Vasodilators are going to dilate arterioles and relax those precapillary sphincters. This is ultimately going to increase flow into the capillary beds. Vasoconstrictors, on the other hand, constrict the arterioles and contract those precapillary sphincters, and this decreases flow into the capillary beds. Then there's autoregulation. This is the process by which the tissue controls local blood flow. So when tissue activity increases, varied stimuli are going to signal that there's inadequate perfusion, and they're going to act as vasodilators. For example, oxygen and nutrient levels decrease, carbon dioxide, lactic acid, hydrogen ions, and potassium increase. This works by a negative feedback mechanism. So as perfusion increases, the vessels are going to constrict in response. Then there's this thing called reactive hyperemia. This is an increase in blood flow after it's been temporarily disrupted. And this happens because additional blood flow is required to resupply that oxygen, those nutrients, and eliminate all those wastes that have built up. An example here is flushing after entering a warm room from being outside in the cold. Okay, other things that can affect short-term blood flow. Inflammation. So here, damaged tissues, leukocytes, and platelets all release vasoactive chemicals. For example, histamine and bradykinin. These guys cause arterioles to dilate. And this is to allow influx of not just nutrients, but also cells that help repair the damage. So again, these guys are going to be released in response to things like trauma, allergy, infection, even exercise. And they can also stimulate the release of nitric oxide, which is another potent vasodilator. Now, sometimes tissue damage can lead to the release of vasoconstrictors, for example, leukotrienes and thromboxanes, for example, to help prevent blood loss through a damaged vessel. Okay, and then finally, of things that influence local blood flow, total blood flow. This is the amount of blood transported through the vasculature per unit of time. Total blood flow is going to equal cardiac output. Remember, that's about 5 liters per minute in the average adult at rest. Total blood flow tends to increase significantly with exercise, and with that increase, there's more blood available to the tissues. Regulation of total flow is going to depend on the heart and the vessels. So remember, that's going to include things like how much blood the heart is able to pump out, or stroke volume, how quickly the heart is pumping, heart rate. Remember, heart rate times stroke volume is cardiac output. It's also going to depend on things like the resistance in the vasculature, and we'll talk about that here in a little bit. Okay, let's move on to blood pressure. What is blood pressure? Well, it's the force that blood exerts against the vessel wall. There's the blood pressure gradient. This is the change in blood pressure from one end of the vessel to the other, and it's this gradient that propels blood through the vessels. Remember, blood's going to move from areas of high pressure to areas of low pressure. Pressure is highest in the arteries and lowest in the veins. Okay, let's talk about arterial blood pressure. So your arterial blood pressure is going to be measured as a ratio. It's going to be a ratio of the systolic pressure to the diastolic pressure. Now, systolic pressure occurs when the ventricles contract. This is systole, and this is going to be the highest pressure generated in the arteries. That is, they are stretched. Again, it's recorded as the upper number of the blood pressure ratio. So if the blood pressure is 120/80, systolic pressure is 120. Diastolic pressure occurs when the ventricles relax, that is, during diastole. This is going to be the lowest pressure that's generated in the arteries, that is, they recoil. It's going to be recorded as the lower number of the blood pressure ratio. So if blood pressure is 120/80, the diastolic pressure is 80. Pulse pressure. Pulse pressure is the difference between systolic blood pressure and diastolic blood pressure. And if you think about it, pulse pressure, what it really is the pressure in the arteries that's added by the heart's contraction. So in our example blood pressure of 120/80, the pulse pressure would be 120 minus 80, so it would equal 40. And this is going to reflect the elasticity and the recoil of those arteries. Pulse pressure tends to decline as you age and with certain diseases. Pulse pressure is what allows for palpation of a throbbing pulse in the elastic and muscular arteries. Pulse, this is the throbbing of an arterial wall. This allows the determination of a heartbeat. More forceful pulse is going to be associated with higher pressure, and the absence of a pulse indicates that blood flow to that body region or body part is lacking. Pulse points are areas where the artery may be compressed against a solid structure, so you're feeling for a pulse on a patient. For example, the radial pulse, you can feel for the common carotid pulse, the femoral pulse, the dorsalis pedis, and others. Okay, so here is a graph showing blood pressure versus the vessel type. Here you have your aorta. And so you can see the systolic pressure here about 120, diastolic pressure is about 80, and you can see the pulsations here, this waveform that occurs with each beat of the heart. You can see that systolic and diastolic pressure are both dropping until they get to the capillaries, and then there's really no difference because there's no pulse in the capillaries, and there's no pulse in the veins either. Mean arterial pressure. What is this? Well, this is the average arterial blood pressure across the entire cardiac cycle, that is, from systole through diastole. Now, diastole lasts longer than systole, so the mean arterial pressure is going to be weighted to be closer to the diastolic pressure, since the cardiac cycle is composed mostly of diastole. So MAP is diastolic pressure plus 1/3 of the pulse pressure. So if our blood pressure is 120/80 and pulse pressure is 40, MAP would be 80 plus 40 divided by 3, or 93. And this gives you an overall idea of perfusion throughout the body. For example, in patients who have a MAP below 60, generally that can indicate insufficient blood flow, and we're especially worried about blood flow to the brain. Okay, capillary blood pressure. So we said the blood pressure in the capillaries is no longer going to fluctuate between systolic and diastolic. So flow and pressure are going to be smooth. Capillary blood pressure needs to be high enough to allow for exchange of substances, but it needs to be low enough not to damage the vessels. The arterial end of the capillary is usually at about 40 millimeters of mercury, while the venous end of the capillary is below 20 millimeters of mercury. Okay, let's pause a second and talk about cerebral edema. So what is cerebral edema? Excess accumulation of interstitial fluid in the brain tissue. This is going to lead to increased intracranial pressure, or ICP, and ultimately impaired brain function. Causes here, so elevated MAP. A highly elevated MAP can overwhelm the autoregulatory mechanisms of the body and essentially push fluid out of those vessels into the brain tissue. Increased permeability of the blood-brain barrier can also do it. This allows fluid to leak across. Trauma, stroke, infection, and even tumors can also trigger edema. So what's the problem with cerebral edema? Well, the brain swells and you can get reduced cerebral perfusion. This is because the brain is held in the cranium, which is a non-expandable compartment. So even though the brain is getting bigger, the skull is not expanding with it. So you get a buildup of pressure inside of the brain, and that pressure can cut off blood vessels. In addition to that, we worry about herniation. This is where that pressure pushes on pieces of the brain and can cut off blood flow to those pieces of the brain, or parts of the brain can even herniate through the foramen magnum and compress the brainstem. And of course, that's going to interfere with your autonomic functions, things like heart rate and blood pressure. Why it matters. So rapid intervention is going to be critical here to prevent permanent damage or death to the patient. How do we manage it? We manage it with osmotic agents. So, for example, mannitol. If you put mannitol IV, it goes through the bloodstream, up through the vessels in the brain, and pulls fluid into the bloodstream. You also need to elevate the head, right? Try to keep blood and fluid flowing downwards with gravity. And in worst case scenarios, they may have to do surgical decompression, where they take a piece of the cranium and remove it to allow the brain to expand. Here's an example of cerebral edema due to a right middle cerebral artery infarct. And why this happens in response to a stroke? Well, you have oxygen deprivation in this tissue here, and these cells, in response to lack of oxygen and nutrients, they lose the ability of their sodium-potassium pumps to work effectively. So they lose the ability to control the osmotic gradient across their cell membrane, and so they have an influx of sodium and water. And they swell. Okay, venous blood pressure. So venous return of blood to the heart is going to depend on a few things: on the pressure gradient, on the skeletal muscle pump, and on the respiratory pump. So remember, venous pressure is very low and it's not pulsatile. The pressure gradient in the venous system is small. Blood pressure in the venules is only about 20 millimeters of mercury, and it's essentially 0 in the vena cava. Now, how is blood going to be returned to the heart then? Well, we've got a couple of pumps. We have the skeletal muscle pump and the respiratory pump. The skeletal muscle pump is going to assist venous return from the limbs. So as muscles contract, veins within them are going to be squeezed and blood is going to be pushed, and those valves that we talked about are going to prevent backflow of the blood. So overall, blood is gradually going to be moved up the vein, and it's going to be moved more quickly during exercise. During inactivity, prolonged inactivity, blood can pool in the leg veins. Okay, here is an image of the skeletal muscle pump. So let's say this is a vein in the leg. This area down here would be towards the feet. This area up here is towards the heart, so blood needs to return this way. And as these muscles contract, they squeeze blood in these veins, and blood is going to be pushed in both directions, both superiorly and inferiorly. However, when it moves inferiorly, it meets valves, and it shuts those valves closed. So really, blood only has one option, that is to travel superiorly. Okay, then you have the respiratory pump, and what it does is it assists venous return in the thorax. Now, both inspiration and expiration are going to come into play here. During inspiration, the diaphragm is going to contract, and this is going to increase abdominal pressure while decreasing thoracic pressure. So blood in the abdominal veins is going to be sucked up towards the thoracic cavity. During expiration, on the other hand, the diaphragm relaxes. This is going to increase thoracic pressure while decreasing abdominal pressure. So blood in the thoracic cavity and in those thoracic veins are going to be driven toward the heart due to this increased pressure in the thorax, while blood in the lower limbs are going to be sucked up into the abdominal veins due to the decreased pressure in the abdomen. All right, let's talk about deep vein thrombosis. What this is a thrombus, or a blood clot, in a vein. The most common site here is going to be the calf. Risk factors are anything that causes a hypercoagulable state. So this would be things like immobility, recent trauma or recent surgery, some medications such as oral contraceptives, malignancy, cancer can induce a hypercoagulable state, smoking is known to induce a hypercoagulable state, and some genetic conditions can do it as well. What you see is heat, tenderness, and redness at the site of the clot. There will be pain and swelling in the areas that are normally drained by that vein. And the most serious and most feared complication of DVT, or deep vein thrombosis, is pulmonary embolus. And remember, this is when a blood clot is going to break free. So in this case, a blood clot from a deep vein breaks free, and then it travels up through the circulatory system until it reaches a pulmonary artery, and it blocks that pulmonary artery. Now, if it blocks a large enough pulmonary artery, it can cause acute respiratory failure and even sudden death. Okay, varicose veins, what are these? These are dilated and tortuous veins. That is, they have lots of twists and turns. What happens here is the valves become non-functional, and so this can cause blood pooling in those veins, and it can cause distension and twisting of the veins. Most commonly you see this in the superficial veins of the lower limbs, and here gravity is going to be a big factor. Varicosities are the result of genetics, aging, extended standing, obesity, and even pregnancy. Hemorrhoids are one manifestation of varicose veins, and these are due to increased abdominal pressure. All right, let's talk a little bit about the blood pressure gradient in the systemic circulation. So the systemic gradient is going to be the difference between the blood pressure in the arteries near the heart and the blood pressure in the vena cava. Remember that the mean arterial pressure, or the MAP, is, in our example, 93, and blood pressure in the vena cava is around 0. So the blood pressure gradient here is going to be 93 millimeters of mercury. This is the driving force to move blood throughout the whole of the systemic vasculature. An increase in this gradient is going to increase total blood flow. How can you increase this gradient? Well, you can increase cardiac output. Remember, this is heart rate times stroke volume. And increasing either one of these components is generally going to result in an increase in arterial pressure. Inotropic agents also play a big role. Remember, these guys cause an increase in contractility of the heart, which increases the force that's generated and increases the pressure that's applied. Okay, let's talk about circulatory shock. This is a really important one to know. You are very likely in your healthcare careers to come across a patient in some kind of circulatory shock. So what is shock? Well, it's a life-threatening condition where tissue perfusion is inadequate to meet cellular metabolic needs. There are several different forms of shock to be aware of. There's cardiogenic shock. This occurs when the heart cannot pump enough blood forward to perfuse the tissues. You see this in conditions like myocardial infarction or exacerbation of congestive heart failure. There's hypovolemic shock. This is where there's not enough blood in the circulatory system to generate adequate pressures for perfusion. So you see this in hemorrhage and severe dehydration. There's distributive shock. Here there's a problem distributing the blood. So there's enough blood and the heart's working fine, but there's not enough resistance in the peripheral vessels, and we'll talk about resistance here in a second. But you need it in order to maintain adequate pressure in those vessels in order to perfuse. Examples here would be things like sepsis, and anaphylactic shock is a kind of distributive shock. Another kind of distributive shock is neurogenic shock. This happens when the spinal cord injury results in the loss of sympathetic tone. And then there's obstructive shock. What happens here is there's a large blockage somewhere in the circulatory system that's preventing blood from being able to move forward. Examples here include large pulmonary embolisms and cardiac tamponade. Remember, this is where that pericardial cavity fills up with fluid and presses against the heart chambers and doesn't allow those heart chambers to expand with blood. So the heart cannot push enough blood forward in order to perfuse the body. Rapid identification and type-specific treatment is going to be crucial in order to correct shock. Resistance. I just mentioned resistance. What is it? Well, it's the friction that blood is going to encounter as it travels through a vessel. It's due to contact between blood and the vessel wall itself, and it opposes blood flow. Peripheral resistance is the resistance of blood in the blood vessels as opposed to the heart. Resistance is going to be affected by blood viscosity, the length of the vessel, and the size of the lumen of that vessel. Okay, viscosity. This is the resistance of fluid to its flow. So the greater thickness, the greater the viscosity, and this is going to increase resistance. Viscosity is going to depend on the percentage of particles in the fluid. So blood has formed elements and proteins, and this makes it about 5 times more viscous than water. Viscosity is going to decrease with anemia, right? This is a low red blood cell count, so there's going to be fewer formed elements and therefore a lower percentage of particles in the blood. Viscosity is going to increase with blood doping. This is going to be a high red blood cell count, so you're going to get the opposite effect. Dehydration is also going to increase viscosity. This is because you lose fluid, so you have a greater concentration of cells and proteins. Increasing the length of the vessel is going to increase resistance. This is because friction is occurring along the length of the vessel. Vessel length typically stays constant, but weight gain or weight loss can change the length of vessels. So weight gain is, we said, associated with angiogenesis. So this is going to increase resistance in the systemic circuit, while weight loss is associated with vessel regression. So this is going to decrease resistance in the systemic circuit. Lumen size is also going to affect resistance. So the vessel radius is going to be 1/2 of the diameter of the lumen of the vessel, right? Because radius is 1/2 of the diameter. So a smaller radius is going to create more resistance. That is, the smaller the lumen, the higher the resistance. Blood has what's called laminar flow. And what this means is that there's a different flow rate within the vessel. So flow of blood is going to be fastest in the center of the lumen, but slower near the vessel wall, and that's because the vessel wall is creating friction, which is resistance. As the radius of the lumen increases, resistance is going to decrease and flow is going to increase. This is because as radius increases, there's relatively less blood that's flowing along the vessel wall. Now flow is going to be proportional to radius to the 4th power. For example, if the radius doubles from 1 millimeter to 2 millimeters, the change in blood flow is going to be 16 times greater. That is 2, because it doubled, 2 to the power of 4. If the radius were to triple, a change in the flow would be 81 times greater. That is 3 for tripling to the power of 4. Okay, so let's talk about the relationship of blood flow to blood pressure gradients and resistance. Let's kind of put it all together and get the big picture here. So what was total blood flow? Well, it's the amount of blood moving through the system per unit time. Now, blood flow is going to be proportional to the pressure gradient divided by resistance. You can express that mathematically with this formula here. F, or flow, is proportional to delta P, or the change in pressure, over R, or resistance. Now delta P here, we're talking about the systemic blood pressure gradient. Okay, so this is the change in pressure. Remember, this is going to be the difference between the pressure in the arteries near the heart and the pressure in the veins near the heart. And remember, we said in our patient who had a blood pressure of 120/80 that their systemic blood pressure gradient was about 93 millimeters per mercury. Okay, so let's look back at this formula and let's ask ourselves, how can we increase flow? Well, you can increase flow by increasing the top number here, so the blood pressure gradient, or you can increase flow by making this number on the denominator smaller, the resistance smaller. So this means that as that blood pressure gradient increases, total blood flow increases. And we generally increase the gradient by increasing cardiac output. And remember, resistance, as it increases, total blood flow is going to decrease, okay? So if we decrease resistance, we increase flow. If we increase resistance, we decrease flow. Resistance can be increased by increasing the blood viscosity, increasing the vessel length, or decreasing the lumen diameter of the vessel. All right, now let's just talk a little bit about the regulation of blood pressure and blood flow. So blood pressure needs to be kept in a proper range. It needs to be high enough to maintain tissue perfusion, but not so high that it damages the vessels. Pressure is going to depend on cardiac output, resistance, and the volume of blood you're working with. And these variables are going to be regulated by both the nervous and the endocrine systems. Okay, let's talk about neuroregulation first. So autonomic reflexes are going to regulate blood pressure, at least short-term changes in blood pressure. There's a homeostatic system that's going to be regulated by negative feedback, and this is going to include components of a reflex arc. It's going to involve nuclei or cell bodies in the medulla oblongata. These guys quickly adjust cardiac output, resistance, or both to meet momentary pressure needs, such as standing up from a seated position. Components of this arc are going to be baroreceptors, sensory neurons, the cardiovascular center, this is the control center, the motor neurons of the autonomic nervous system, and the heart and blood vessels, which are the effectors. Okay, first you have baroreceptors. These guys are receptors that respond to stretch of the vessel. They're going to be located in the arch of the aorta as well as in the carotid sinuses. They relay nerve signals along sensory neurons to the brain, and from there the brain interprets that signal and decides whether to make a change to increase resistance, decrease resistance, increase heart rate, decrease heart rate, etc. Now, where do these sensory neurons go? Well, they synapse with neurons in the cardiovascular center of the medulla oblongata. And remember that cardiovascular center contains two autonomic nuclei, the cardiac center and the vasomotor center. The cardiac center is going to influence blood pressure by influencing cardiac output, while the vasomotor center is going to influence blood pressure by influencing vessel diameter. Now remember, in the cardiac center, there are two nuclei. There's the cardioacceleratory center and the cardioinhibitory center. The cardioacceleratory center is going to make the heart beat faster and harder, okay? It's the origin of sympathetic pathways. And these paths extend to the SA node as well as the myocardium. And activity here is going to increase the heart rate as well as the force of contraction. And this increases cardiac output and therefore blood pressure. The cardioinhibitory center, on the other hand, is the origin of parasympathetic pathways. This guy is going to extend to the SA and the AV nodes. And parasympathetic activity here is going to decrease heart rate and slow the conduction of electrical signals, and this is going to work to decrease cardiac output and lower blood pressure. Okay, that was the cardiac center of the cardiovascular center, but remember there's also the vasomotor center. So what does the vasomotor center do? Well, it's going to control vessel constriction and dilation. Pathways are going to extend from the vasomotor center to blood vessels, where the motor neurons there release norepinephrine. Sympathetic activation is also going to stimulate the adrenal medulla to release epinephrine and norepinephrine, and those guys get circulated in the bloodstream. Now, most blood vessels, smooth muscle cells, have these receptors, the alpha-1 adrenergic receptors. Remember, adrenergic means it responds to things that the adrenal glands release, that is epinephrine and norepinephrine. So every time you see adrenergic, you need to be thinking norepinephrine and epinephrine. Now, when norepi and epi bind to these alpha-1 adrenergic receptors, they're going to cause vessels to constrict. Some blood vessels, smooth muscle cells, have these receptors, the beta-2 adrenergic receptors. Again, these guys are going to respond to epi and norepi. And here, norepi and epi are going to cause vasodilation. Okay, so remember, norepi and epi's action really depends on what receptor they are acting on. All right, so this sympathetic activation and this adrenal secretion are going to lead to increased peripheral resistance. That is, there's more blood vessels that are stimulated to constrict than there are to dilate, so the blood pressure is going to increase. It's going to lead to larger circulating blood volume, vasoconstriction of the veins, remember where most of our blood is stored. Vasoconstriction of those veins is going to shift blood out of those venous reservoirs into the rest of the systemic circuit, and this is going to increase blood pressure. Next, it's going to lead to redistribution of blood flow. So you're going to get more blood going to your skeletal muscles and to your heart, and less blood's going to go to other organs such as the gut and the kidneys. Now, inhibition of sympathetic activity is going to reverse these changes. All right, so let's take a glance at how it all works. So we start out here with our baroreceptors, right, in the aortic arch and in the carotid body. These guys detect stretch, and that detection is going to alter input to a sensory neuron. These signals are going to be relayed along sensory neurons up to the control center here, which is the cardiovascular center. Remember, that's going to include the cardiac center and the vasomotor center. These centers receive and respond to that sensory input, and they alter their motor output. So motor output is going to be sent along motor neurons, and it's going to be relayed to the effectors, to the blood vessels, and to the heart. The green neurons here are showing sympathetic pathways. So sympathetic activity might increase the diameter of certain blood vessels, might decrease the diameter of other blood vessels, and it will work on the myocardium to cause the heart to beat faster and stronger. These golden colored neurons are showing parasympathetic pathways. So you see the right vagus nerve interfaces or synapses with the SA node, while the left vagus nerve synapses with the AV node. And there they exert their effects on heart rate. Okay, so here's that baroreceptor reflex in a little bit more detail for you. So if blood pressure decreases, vessel stretch is going to decline, and the baroreceptors are going to detect that, and their firing rate is going to decrease. That decrease in firing rate is simultaneously going to activate the cardioacceleratory center and inhibit the cardioinhibitory center. Activating the cardioacceleratory center is going to stimulate sympathetic pathways to increase cardiac output, while inhibiting the cardioinhibitory center, you inhibit the inhibitor, you're minimizing parasympathetic activity, you're ultimately going to increase cardiac output. And it's going to activate the vasomotor center as well to stimulate the sympathetic pathways to increase vasoconstriction. This increase in cardiac output and resistance is going to raise blood pressure. On the other hand, if blood pressure increases, vessel stretch is going to increase and baroreceptor firing rate is going to increase. This is going to cause the cardioacceleratory center to send less signals along those sympathetic pathways, so it turns down the sympathetic input, and it's also going to stimulate the cardioinhibitory center to activate parasympathetic pathways to the SA and the AV nodes. In addition to this, it's going to cause the vasomotor center to send fewer signals along those sympathetic pathways to blood vessels. So this is going to result in a decrease in cardiac output and a decrease in resistance, and ultimately lower blood pressure. Now remember, baroreceptor reflexes are going to be used for quick changes in blood pressure, such as going from a seated to a standing position. They're going to be ineffective for long-term blood pressure regulation. All right, chemoreceptor reflexes also influence blood pressure. So chemoreceptor stimulation is going to bring about a negative feedback reflex that returns blood chemistry back to its pre-stimulus levels. And here you're going to see responses in the respiratory and the cardiovascular systems in response to chemoreceptor detections. So the main peripheral chemoreceptors are in the aortic and carotid bodies, just like those baroreceptors. Both are going to send the input to the cardiovascular center. The aortic bodies are in the aortic arch, and they're going to send signals via the vagus nerve. The carotid bodies are at the bifurcation of the common carotid artery. These guys send signals via the glossopharyngeal nerve. Now, what are the stimuli that the chemoreceptors are detecting? High carbon dioxide, low pH, that is acidemia, and very low oxygen. And these are going to stimulate chemoreceptors and the vasomotor center. And ultimately, you're going to see an increase in blood pressure and a shift of the blood over to the lungs, which are then going to be able to expire CO2, increase their expiration of CO2, and therefore help raise blood pH. Higher brain centers can also regulate blood pressure. So the hypothalamus can increase cardiac output and resistance. Don't forget, it's the integration and command center for autonomic functions. So what it does is it's going to send descending signals to autonomic centers in the brainstem, and as well as the spinal cord. And here, those signals influence heart rate and blood pressure, as well as other autonomic functions. The limbic system can also alter blood pressure, and this is in response to emotions or memories. Okay, then there's hormonal regulation of blood pressure. So several hormones participate in regulating blood pressure. Typically, they're going to alter resistance or alter blood volume or alter both. Now remember, blood pressure is going to be influenced by blood volume. Volume is a function of fluid intake and fluid output. You get your intake through drink and food, and this is going to be directly related to blood volume, so more intake, higher blood volume. Output is going to be through expired air, sweat, transpiration, this is from the skin, feces, and urine. Now, out of all of these ways that we lose fluid, typically only urine output is the one that's going to be regulated. And output is going to be inversely related to blood volume. So the greater output, the less blood volume you have. Okay, let's start with antidiuretic hormone, or ADH. This helps maintain or elevate blood pressure. This guy's going to be released from the posterior pituitary. And remember, release is going to be triggered by nerve signals from the hypothalamus. The hypothalamus is going to be stimulated by increased blood osmolarity, that is, an increased concentration of solutes in the blood, or by angiotensin II, and we'll talk about that here in a second. Antidiuretic hormones effects, so it increases water reabsorption in the kidney, so you get less fluid loss. This helps maintain blood pressure. It stimulates the thirst center to increase fluid intake. This is going to help raise blood volume. And in very large amounts, it actually causes vasoconstriction, increasing resistance and blood pressure. And so for this reason, ADH is also sometimes called vasopressin. Aldosterone is another hormone. It's going to help maintain blood volume and blood pressure. This guy is released from the adrenal cortex, and it increases absorption of sodium ions in the kidney. And with this absorption of sodium ions, water is going to follow. Okay, so ultimately, the ultimate effect of aldosterone is to decrease urine output. Okay, then you have the renin-angiotensin-aldosterone system, or the RAS. So just to start off, the liver makes this protein called angiotensinogen, and it releases it into the blood, and it's doing this all the time. And this protein is inactive. The kidneys are going to release this protein called renin into the blood in response to low blood pressure or sympathetic nervous system activity. So when renin gets released into the blood, it can interact with angiotensinogen, and it converts angiotensinogen into angiotensin I. Then angiotensin I is just floating through the bloodstream, and it comes across angiotensin converting enzyme, or ACE. And ACE converts angiotensin I into angiotensin II. And this enzyme, the ACE enzyme, is located in the capillaries of the lung. So now that we've made angiotensin II, what does it do? Well, it raises blood pressure. It's a powerful vasoconstrictor, so it's going to raise resistance. It stimulates the thirst center, so fluid intake is going to increase, which is going to increase blood volume. It's also going to act on the kidneys to decrease urine formation. So there's less fluid loss from the blood. This helps maintain blood volume. It stimulates the release of antidiuretic hormone and aldosterone. All three hormones, angiotensin II, ADH, and aldosterone, cause the kidneys to reduce urine output. So you can see angiotensin II's effects are pretty widespread. Next, you have atrial natriuretic peptide, or ANP. This guy decreases blood pressure. So what's going to happen is when the atria of the heart stretch by a high blood volume, they're going to release this hormone. And this hormone, ANP, goes and stimulates vasodilation. That is, it decreases peripheral resistance, and it works to increase urine output. It increases urine output by increasing sodium loss at the kidneys. So that's where natriuretic comes from, natriuresis, or sodium secretion. And so water follows sodium, so you get more urine output, more urine formation and urine output. Okay, let's talk about measuring blood pressure. So there's several ways to measure blood pressure, but the way that you're most familiar with is going to be the indirect method using a sphygmomanometer or blood pressure cuff. What you do is you wrap the cuff around the arm and you put the stethoscope on the brachial artery. You inflate the cuff until you completely compress the brachial artery, so you're cutting off blood flow to the distal arm. Now, pressure in the cuff is then going to be gradually decreased by releasing air from the cuff, and you're listening to the brachial artery as you do that. What you're listening for are these sounds, Korotkov sounds. What happens is you hear the first sound when the blood pressure in the artery is sufficient enough to overcome the pressure being exerted on it by the blood pressure cuff. Okay, and this is going to tell you your systolic pressure, or the maximum pressure, the pressure that your heart generates during systole. And the reason you hear this sound is because the pressure is opening up that artery a little bit, and you're hearing turbulent blood flow through that partially open artery. Now, you're going to continue to release the blood pressure cuff until you stop hearing the Korotkov sounds. This tells you the diastolic pressure. This is the pressure in the arteries when the heart relaxes, and you no longer hear those sounds because the flow has smoothed out. It's not cut off anymore. All right, we'll talk a little bit about hypertension and hypotension. So what is hypertension? It's elevated blood pressure. You've got a couple stages here. Stage 1 is when systolic pressure is greater than or equal to 130 millimeters per mercury, and or diastolic is greater than 80 millimeters of mercury. Then you've got stage 2, and this is going to be any blood pressure that's greater than 140/90. Now, the problem with high blood pressure is that it can cause damage to the blood vessel walls, and it can make atherosclerosis or aneurysms and dissections more likely. High blood pressure can also harden the arterial walls. This is called arteriolosclerosis. And chronic hypertension is a major cause of heart failure. The left ventricle has to work much harder to overcome high blood pressure in order to push the blood forward in the systemic circuit. And remember, high blood pressure, that's an increase in afterload. Next, you can have hypotension. This is low blood pressure. Symptoms here frequently are fatigue, dizziness, fainting, or syncope. What you see in hypotension is a systolic pressure less than 90 and or a diastolic less than 60. You can have orthostatic hypotension. This is a drop in blood pressure after you suddenly stand from usually a seated position. And you get dizziness, you get lightheadedness, and you can even faint. This is due to those baroreceptors and that whole blood pressure regulation, that short-term, quick change blood pressure regulation system. It's not adapting quickly enough. Okay, how does blood flow distribution change during exercise? Well, total blood flow is going to increase during exercise in order to meet metabolic needs. So you're going to see the heart beat faster and stronger. Blood is going to be removed from those venous reservoirs and kicked into the systemic circuit. Blood is redistributed so that more goes to the active tissues, the skeletal muscle that's working. For example, flow to coronary vessels is going to increase so the heart wall gets oxygen. Flow to the skin is going to increase in order to dissipate the heat that's being made. We said skeletal muscle blood flow is going to increase. It increases drastically to meet the muscle's demands. And then you're going to have less blood going to the organs in the abdomen, less blood going to the kidney, so less urine is being made. Here on the left, you can compare total blood flow at rest. So total blood flow or cardiac output is 5.25 liters per minute. Over here, it's 17.5 liters per minute with strenuous exercise. You can see the increased blood flow. Here, during exercise, the brain is getting 750. During rest, it's only getting 650. The heart at rest, 250. During strenuous exercise, 3 times as much. Skeletal muscles, I want to draw your attention to. 1,100 milliliters per minute here at rest. 12,500 milliliters per minute during exercise. Okay, so big changes going on to your blood volume and your blood flow during exercise. Okay, and just a mention of the pulmonary circuit. So compared to systemic circulation, pulmonary vessels are going to have less elastic connective tissue. They're going to have wider lumens. They're relatively short, right, because the lungs are close to the heart, and they have a lower blood pressure within them. Blood leaves the right ventricle with a systolic pressure of only 15 to 25 millimeters of mercury. Compare that to the left ventricle, which is pumping blood out at a systolic pressure of 120 millimeters of mercury. Now pressure is going to drop down to 10 millimeters of mercury in the pulmonary capillaries, and this is going to ensure slow movement and good gas exchange. Now remember, blood is going to exit the pulmonary capillaries and enter those larger pulmonary veins. And as the pulmonary veins enter the left atrium, the blood pressure drops to almost 0 millimeters of mercury. Okay, now let's talk a little bit about the fetal circulation and compare it to the postnatal circulation, and this will end our discussion on vessels. So some differences between the fetal and the newborn circulation. Remember that the fetus is going to receive its oxygen and its nutrients through the placenta, while the newborn's cardiovascular system is independent. Fetal lungs are going to be non-functional, so blood pressure on the right side of the heart is going to be greater than on the left side of the heart because you don't really have blood pumping through the pulmonary trunk. Fetal vessels are going to shunt blood to the organs that need them and shunt blood away from immature organs that aren't in need of blood right now. What path does blood take in the fetus? Well, oxygenated blood from the placenta is going to come to the fetus through the umbilical vein. Remember, veins carry blood towards the heart. In this case, the umbilical vein is carrying blood towards the fetus's heart. Blood from the umbilical vein is going to be directed straight toward the inferior vena cava through a vessel called the ductus venosus. Now that oxygenated blood in the ductus venosus is going to mix with the deoxygenated blood in the inferior vena cava. That blood then joins blood from the superior vena cava and empties into the right atrium. Now, most of the blood is going to be shunted from the right atrium to the left atrium via that foramen ovale. Remember, that's that hole in that interatrial septum. So this blood gets shunted from right atrium to left atrium, and then it flows into the left ventricle, and it's going to be pumped out through the aorta to the tissues in the fetus's body. There's a small amount of that blood that's going to, instead of being shunted from the right atrium to the left atrium, that's going to enter the right ventricle. And that right ventricle is going to pump it to the pulmonary trunk. However, most of that blood in the pulmonary trunk is going to be shunted to the aorta through the ductus arteriosus. Blood is then going to travel from the aorta to the rest of the body and return to the placenta through a pair of umbilical arteries, and nutrient and gas exchange is going to occur at the placenta. So what happens at birth? Well, fetal circulation begins to change to the adult pattern. With baby's first breath, the pulmonary arteries are going to dilate so that pulmonary resistance drops dramatically. This is going to decrease pressure on the right side of the heart. Now you're going to have pressure greater on the left side of the heart than on the right side of the heart. After birth, the umbilical vein and the umbilical arteries are going to become non-functional. The umbilical vein becomes the round ligament of the liver, while the umbilical arteries become medial umbilical ligaments. The ductus venosus stops being functional, and it constricts, and it becomes the ligamentum venosum. The foramen ovale is going to close, so that higher pressure on the left side of the heart is going to push the flaps of that interatrial septum closed, and this is going to close up the foramen ovale. Remember that there's a remnant of that foramen. It's called the fossa ovalis, and it's a small depression in the right atrium. There's the ductus arteriosus. It's going to close within 10 to 15 hours of birth, and it becomes a fibrous structure called the ligamentum arteriosum. Okay, what happens if that ductus arteriosus doesn't close after birth? Well, that's called patent ductus arteriosus. So what happens after birth is you'll see that blood pressure is now going to be higher in the aorta than it is in the pulmonary trunk. Before birth, pressure was higher in the pulmonary trunk than in the aorta. Okay, so blood moved from the pulmonary trunk through the ductus arteriosus into the aorta and out to the rest of the fetus's body. After birth, blood pressure is higher in the aorta, so blood is going to flow from the aorta into the pulmonary circulation. This is going to cause pulmonary hypertension, or high blood pressure in the pulmonary circulation. It's also going to cause a mixing of deoxygenated blood with oxygenated blood. Now, how do they treat this? They can treat it with prostaglandin inhibitors. They can also treat it with surgery. So why prostaglandin inhibitors? Well, in the fetus, prostaglandins keep the ductus arteriosus open. So inhibiting those prostaglandins after birth helps to close it. What is an example of a prostaglandin inhibitor? Ibuprofen. Ibuprofen inhibits prostaglandins, and so this is why pregnant women are advised not to take ibuprofen. And then sometimes a patent ductus arteriosus requires surgical closure.